All right, it is 9:35, so it is time to get started with our next speaker. Now, the next speaker I have on my agenda for the event is Dr. Juan Cardet, who's going to be here with us to talk about the use of anti-inflammatory drugs to close racial gaps in asthma outcomes. So let me give you just a little bit of background on Dr. Cardet, who is an assistant professor in the USF Department of Internal Medicine, specializing in the treatment of patients with asthma, chronic rhinitis, and other allergic and immunologic diseases. Like most of our speakers, Dr. Cardet does a combination of research, education, and service, as well as clinical care. Dr. Cardet's focus specifically is on health equity and asthma outcomes among Black and Latin adults, which is a huge focus for us with the Florida Asthma Coalition and program. So Dr. Cardet, the floor is yours.
Thank you again for that kind introduction. What I was saying was I want to disagree a little bit with the title of the talk. I'll start with that because even though I'm going to show you the evidence for why this intervention I'm going to talk about was effective, I'm not sure about reducing a racial gap. Hopefully, it improves outcomes for all racial groups, and that doesn't necessarily reduce a racial gap, right? And we can get to that in a second. So what I wanted to talk to you about are social determinants of health in asthma and this low-cost intervention that was effective in reducing asthma attacks in a population re-recruited of Black and Latinx adults with moderate severe asthma. You can see my colleagues on screen. These are my conflicts of interest, all unrelated to the presentation, our funding support, and our disclosures. First, here's an outline of my talk, social determinants of health. I'll also talk about the burden of disease from asthma in Black and Latinx. Perhaps you have seen some of these numbers before. And also, and importantly, and I'm excited about this, it's the results of our PCORI-sponsored PREPARE trial. So here are some of the learning objectives. Perhaps you have that from the course materials. So let's get to it. So social determinants of health, and I'll just read this. These are the conditions, the environments where people are born and live, essentially that affect a wide range of health, functioning, and quality of life outcomes. There are 5 domains, and these feed into health disparities, which I think is important for everybody attending this. They include poor education, access and quality, the neighborhood and the built environment, social and community context, economic instability, and poor healthcare and quality. Davis and others from the American Academy of Allergy, Asthma, and Immunology got together last year and put together a very well summarized article on social determinants of health, and some of this information can also be found in health.gov. So what do we talk about when we say health disparities? So preventable differences in the burden of disease experienced by socially disadvantaged groups, especially relative to less disadvantaged or not disadvantaged populations. And then the last term I think we should consider, they're all related, but there's nuances. It's minority health. Minority health of a population, it's independent of a comparison relative to other populations. So let's break that down. So those 5 components of social determinants of health as we know them. So poor education, access, and quality. So for these populations, high-paying jobs are less likely, which drives chronic diseases, which drives poor outcomes. There's solid data behind it. Neighborhood and built environment, for example, how much violence you can get exposed to where you live, if there's like safe drinking water, or if the air is breathable, if there's excessive noise, how much transportation that can get you where you're allowed to do your things, activities, social and community context. So relationships and how the environment allows you to have relationships that bring you well-being into your life, and whether there's a discrimination component, or there's a racism or a violence component into it. Economic instability. So despite being the most affluent nation probably in the history of the planet, 10% of the US lives in poverty, and poverty in itself associates with inability to get healthy foods, housing, healthcare, physical activity opportunities, and it drives poor health outcomes. I can show you some data on that. I will show you some data on that. Poor healthcare quality, 10% of the US remains uninsured, which is associates with inability to pay for meds. And you can see that in asthma in particular. It's interesting. This is an article by Yearby that says that structural discrimination, and you can see that in terms of racism, sexism, by class, by age, by ability, then gets into the law, right, and statutes and the political process, which affects budgetary decisions and law enforcement of those laws, which has an impact on those social determinants of health and has an impact on health. So let's relate all of those abstract concepts to asthma. This is from Beck. It's from a number of years back, published in JAMA Pediatrics. This is from the Cincinnati group. 695 Black and white children from Cincinnati and the greater area with at least one asthma hospitalization. They use this fancy statistical approach, causal inference. Their outcome, the oval to the right, is readmission, hospital readmission for asthma within a year. And of all those factors that you can see on screen, either in an oval or a rectangle, they found that more than 80% of the association between self-reported ancestry and readmissions can be explained by social determinants of health, importantly, disease management, access to care, and environmental exposures. So if you look at, I'm going to show you those data. If Black race associates with a greater prevalence of asthma and also greater morbidity from asthma in terms of ER admissions for asthma attacks and also asthma-related death. And those morbidities that associate with race, according to this group, most of it can be explained by non-ancestral and non-racial factors, but rather social determinants of health. More recently, this group, and this was published by Mersha and Jackie last year, is that now they went back, same cohort, same outcome, right? It's readmission within a year of follow-up for a hospital for an asthma hospitalization. Now they looked into the genetics, not just self-reported Black ancestry, for example. Now they looked at genetic markers for African ancestry, right? And more than 50% of the association between ancestral genetics and readmissions can be explained by social determinants of health. So what about all those individual factors that I talked about within those 5 components of social determinants of health? This is for Thaker. This is from Esteban Burchard's group. You can see here African-American in the left figure, African-Americans, Mexican-Americans, other Latinx, and Islander Puerto Ricans. Anything that's to the right of that vertical dotted blue line is an increase in the current asthma prevalence. Of those, African-Americans have the highest one, 78% higher, as we know. But you can see to the right side of the screen, so the more often that people experience discrimination, the higher the chances of having current asthma prevalence. So 2.6-fold for those who often experience discrimination. This is after adjustment for many different factors. Also, the impact of violence. This is Seema Ratnam. She's now in Wisconsin, and this is from Juan Celadon's group. And this, they looked at 466 children in San Juan. Those are the ages with and without asthma. And you can see that there's a dose responsiveness, I guess, with the combined score of fear of leaving home and or hearing a gunshot. And the higher that score, the greater the proportion of people that have asthma. This is after a multivariate analysis, so after adjustments. Education is important. Also from that same group, Rosa Salazar, but from Juan Carlos Celadon's group, You can see especially that adjusted line, low parental numeracy, how good they're with numbers in an educated fashion, 70% higher the chances of their kids having one or more ED or urgent care visits for asthma in the past year. This is from our group. This is from the secondary analysis of the AsthmaNet VITA trial. Often a criticism from large epi studies is that, it's not really income in itself, it's lack of access to medications, which is a reasonable concern. But in the context of this trial, where inhaled corticosteroids were provided for free and adherence was reinforced with weekly calls, so people who were taking their meds and self-reported to be more than 95% compliant with taking controller inhaled corticosteroids for asthma. You can see in red, it's people who were assigned to placebo. In blue, you can see it's the people assigned to vitamin D. That was the intervention of the trial, but which we don't care about right now. What we care about is comparing the blank squares relative to the filled squares. And you can see that over the course of the trial on the x-axis and the y-axis, you can see the cumulative number of treatment failures, or you can say it asthma attacks, if you will. Those who have lower incomes tend to have greater number of asthma attacks. That's after adjustment. More recently, this is a ancillary study from the PROCORI PREPARE trial, and I'll give you all of the details now. This is IMPRESS and Jackie. We looked at socioeconomic status as a multi-dimensional construct. In the last slide, I only looked at income and looked at also education and perceived stress, but did not build a variable that incorporates many different aspects. So socioeconomic status is not just one thing. It's not just income, right? So for this one, we looked at this variable, low socioeconomic status, composed by poverty, unemployment, and low educational attainment. And we found that indeed it associates. What's neat about this one is that this is in a cohort only of Black and Latinx adults. So rarely do we find that. It's typically minority populations are underrepresented in clinical studies, but this one was exclusively composed by these populations. And even in Black and Latinx populations, low socioeconomic status associated with worse asthma morbidity outcomes. And it seems that we did a mediation analysis, part of it, especially with ER visits, it's mediated by hard perceived stress. This is from the government, so minorityhealth.gov. You can see that in Blacks, the prevalence of asthma is higher in adults, also in children, but I'm focusing on adults. And so is the ER visits for asthma, 2.8-fold, and also the death rate almost 3-fold higher relative to non-Hispanic whites. For Latinx, perhaps you know about this, the story is complicated. Being Hispanic, it's an ethnicity, it's not a race, and it's many different groups, ethnic groups with a shared language. Puerto Ricans and other Caribbean Hispanics tend to have greater asthma morbidity relative to other racial groups, and Mexicans seem to have less, but overall, Hispanics tend to have a higher emergency department visits for asthma relative to whites, and particularly Puerto Ricans have a 4-fold higher death rate from asthma relative to whites. So in summary, social determinants of health are environmental features that impact our health and underlie health disparities. This is so in asthma. Black and Latinx, especially Puerto Ricans, bear a disproportionate burden of disease. Lower socioeconomic status associates with worse outcomes, even if you only look at Black and Latinx adults. And this comes to, I think, an interesting part of the lecture, which is efforts to reduce this burden has been expensive and mostly unsuccessful, but here's something that might work, and we're hoping to get it to clinic. So here's the background to our trial that we recently published, the primary outcome. As needed, so an as needed inhaled corticosteroid strategy, and this might work, and here's why. So Inhaled corticosteroids are a centerpiece of asthma control therapy strategies. We know that adherence to them is low. From refill data, it's only 20 people take 25% of what we think they should be getting. But data show that an as needed inhaled corticosteroid strategy guided by asthma symptoms can improve outcomes. So, for example, the SMART therapy. So symptom-driven as needed use of ICS is now recommended by NAAPP for mild asthma. Twice daily inhaled corticosteroids with formoterol plus additional as needed use is now endorsed by American and international guidelines for moderate severe asthma. SMART has not been tested in Black and Latinx adults. It's in the last EPR4 listed as future directions, right? It's not studied in populations reliant on rescue nebulizers, as you'll see our populations in Black and Hispanics are. Pertinent trials only enrolled patients with an exacerbation history and a demonstrated bronchodilator response, which in clinic you may or may not see, right? SMART therapy requires a patient stopping whatever it is that they're doing for controller therapy and switching them to essentially Symbicort, 2 puffs twice daily, which not everybody can do. I'm seeing a sign participants can now see presentation. I hope that's not true. FDA does not approve the use of as needed ICS formoterol, which is a huge barrier in my clinic at least, and I think in most of yours. And there are insurance and other barriers to SMART. So we thought, in consultation with patient partners, providers, and advocacy groups, that a patient-centered strategy, which we called PARDIX for patient-activated reliever-triggered inhaled corticosteroids, where patients were asked to take 1 puff of ICS, which we provided for free for the duration of the trial, every time they use a rescue inhaler, and 5 puffs of ICS when they use a rescue nebulizer, without having to change their underlying controller therapy or therapy in general, would improve asthma outcomes important to patients and the healthcare system. I'll give you some more detail. This is a prepared trial, pragmatic, randomized, open label. Recruited 1,201 Black and Latinx adults, bad asthma, on ICS that was uncontrolled or had a self-reported exacerbation the past year. We randomized them to PARDIX and gave them extra ICS and asked them to keep their usual care versus the other group, which is continue usual care. All of this instruction happened in only a single in-person study visit. Our primary outcome was asthma exacerbation rates per year, which we captured through monthly surveys, which we administered online in whatever device they wanted to use, or by a phone interview, or by snail mail. Additional pre-specified outcomes included quality of life, asthma control, and days lost from work, school, and usual activities. These are our results. They're published in the April issue of the New England Journal. These are the baseline characteristics. I don't want to get into those details, but essentially characteristics were well balanced across both treatment arms. You'll see that a majority of our population, even more than the rest of the United States, the general population was obese. Many current or former smokers, and many in smoking environments. This is not seen in pharma-sponsored trials. More than 2/3 regularly using NEBs, which is also not accounted for by SMART therapy trials, and more than 2/3 with important comorbidities for asthma. These are primary results. You can see the red dotted line is the usual care group. You can see the blue straight line is the PARDIX intervention, and you can see that there's a decrease in asthma attacks, cumulative number per participant. And the x-axis is the months for the trial. It's about a 15% reduction in exacerbations. When you turn it into per person per year, it's 0.13. This is equal to or greater than what we see with SMART therapy, which was 0.12 per patient per year. You can see the same thing for asthma control. The blue line is the PARDIX intervention, and it's higher than the usual care group. The difference is about 1, but you can see that it was a 3.4 increase in ACT score from baseline, which exceeds the minimally important clinical difference of 3, whereas for the usual care group, it was only 2.5, which does not cross that important MCID, clinically important difference. The same goes for ASUI, Asthma Symptom Utility Index. The difference between them, so it was only clinically significant relative to baseline for the Pardix intervention. Both groups increased, but the Pardix intervention did more so, and it was the only one that did so across that minimally important clinical difference. Pardix also reduced the number of days lost from work, school, and usual activities, which is something crucially important to patients, about a 20% greater number of now days available that go back to work, school, and usual activities. We wanted to find out if our signal was driven by any group in particular, any clinical, demographic, social characteristic. You can see in the red rectangle, that's the primary outcome. So there's a 15% reduction in exacerbation. So anything that you see to the left of that big vertical line of 1 is that it favors the Pardix intervention relative to usual care, which is the right side of the line. You can see that all those points are to the other side. They're favoring Pardix, except for that former current smoker. It may not work as well in them. But then again, that p-value exceeds that threshold that we thought would be important to make a distinction. So we have no evidence to say it works less in current smokers or former smokers. Except for these two, we have evidence to suggest that Pardix works best among those with self-reported exacerbations. This makes sense. This is expected. In fact, smart therapy trials enroll only people who have self-reported an exacerbation in the past year. Why should that be so? If the primary outcome is asthma exacerbations, the best predictor of a future asthma exacerbation is the past one. It's a very low event rate, even among the most severe asthmatics. You might get 1 exacerbation per year. So trying to cut down from that is hard in these clinical trials. The second point is medical adherence by the MARS-5 score. This may work especially well among those with low self-reported adherence to controller therapy. This makes sense. People don't take their controller therapy. It's human nature and behavior. Or supplementing their inhaled corticosteroids at the right time, which is when their body is having asthma symptoms. All of this, you can see the effect of Pardix was incurred with little additional inhaled corticosteroids. The difference between the Pardix intervention group and the usual care group was 1.1 extra inhaled corticosteroid inhalers per year, which is very little, costs very little to the system. Pardix reduces their rescue therapy usage. So we're comparing the left-hand side of the screen to the right-hand side of the screen. Left hand is the Pardix intervention, the right-hand side is the usual care. So compare the blue ones, which is the how much self-reported inhaler puffer for rescue they used, and it's 1 fewer inhaler refill per person per year, or for the duration of the trial. And it also decreased the amount of nebulized rescue albuterol that they were using, about 33% less. You can see that the severe asthma events, severe adverse events that were comparable between the Pardix intervention and the usual care group. We weren't powered to detect differences in ER visits for asthma attacks. I said before that asthma attacks are a low event rate. So actually going to the ER for an asthma attack is even lower than that. So it's hard to detect the difference. But we saw essentially a very comparable difference between the Pardix intervention and the usual care, which is about 16% less, but it was not statistically significantly different. Notice that 95% confident interval crosses the line of 1. Same goes for hospitalizations, even rarer events, but so we're not powered statistically to detect differences, but again, a 16% reduction for Pardix relative to usual care alone, but again, not statistically significantly different because it crosses the line of 1. So in summary, reducing the disproportionate burden of disease from asthma in Black and Latinx patients has been difficult, but we collaborated with patient partner advisors. We demonstrated Pardix, again, patient activated, reliever triggered, inhaled corticosteroid therapy added to their underlying therapy in Black and Latinx adults with moderate severe asthma was well adopted after a single in-person session of training, and it reduced asthma attacks, improved asthma control and quality of life, reduced days lost from work and school. It was homogeneously effective, but maybe most effective among those with low self-reported adherence to control therapy and those with a history of exacerbations. Pardix reduced rescue therapy relative to usual care. Severe adverse events were comparable between arms, and Pardix tended to reduce ER visits, urgent care visits for asthma attacks, and hospitalizations for asthma, but we were underpowered to detect such differences. The reductions we saw in asthma attacks with Pardix were equal or greater than those of relevant SMART trials. Actually, we have some preliminary data. Had we applied that same entry eligibility criteria as for SMART trials, which is self-reported history of asthma attacks, the reduction would have been more like 0.19 exacerbations per person per year, which would have surpassed it. But we would need to show that prospectively, which we're trying to do. Pardix comes at only 1.1 additional ICS canisters per person per year, which is nothing, peanuts for the healthcare system. Pardix was tested in a broad population without restriction of asthma phenotypes. Again, we did not require, as this was a pragmatic trial, a history of exacerbations that are positive bronchodilator response. Does not require changing the underlying control of therapy. I don't need to switch them. The budesonide for Formoterol, they can keep whatever it is that they like to take for control of therapy. Was tested in populations that use rescue nebulizers, as opposed to insisting that people change something that they like, which is rescue nebulizers. And Pardix, as far as we can tell, does not challenge FDA restrictions, which is an easier way to adopt it. And that's it. I would like to acknowledge all our study participants for dedicating their time, their families for trusting us with their time and dedication, and special thanks to our patient partner, patient advocacy, and professional society stakeholders, our study site staff, study site investigators, health policy experts, our coordinators from the AAFP, our medical writer, expert scientific advisors. And here are the co-authors for that socioeconomic status ancillary study that I mentioned. Thank you so much for having me. I'll take questions. That's my email. Please shoot me an email. Happy to address any questions. Happy to collaborate. Interesting. What do you have to say now?
Dr. Cardet, thank you so much. That was a terrific presentation, and I really appreciate that you have left some time for questions. So I'm already seeing some questions coming in on the event chat. We have one person asking, GINA guidelines discussed SMART therapy. Why is it recommended if it's not FDA approved?
That's a great point. I think that experience is more unique to the United States relative to other countries. Perhaps you know about this. So for the longest time, there was a black box warning on long-acting beta agonists, such as that for Formoterol, that's within Symbicort, which is a typical inhaler used in SMART therapy trials, budesonide for Formoterol. There was, oddly enough, it was also called the SMART trial. There was a signal for people who were using only long-acting beta agonists as causing increased morbidity and mortality from asthma. So it's now recognized if you only bronchodilate the airways and you don't treat it with inhaled corticosteroids or other measures to treat the inflammation, then it's asking for trouble. For example, 60s, 70s, there were epidemics from overuse of beta agonists. There's many reasons for that, but again, one important reason is not adequately targeting the inflammatory component of asthma. So there's that black box warning. Recently, or more recently, maybe 8 years ago or something like that, FDA mandated a bunch of trials to address the safety of inhaled corticosteroid long-acting beta agonist combinations. And it was found, to be comparable to high-dose inhaled corticosteroids alone in terms of safety. But still, that there's, for that reason, that increased signal in morbidity and mortality that we saw before, like 15 years ago or something like that, there's that hesitation to give it the free pass and use Symbicort for rescue. Some people are afraid. Well, my patient uses albuterol 20 times in a day, right? What if I'm giving inhaled corticosteroids and formoterol 20 times in a day for a patient? It's, Gina says cap it at 8, but if you unleash it, if you give it out to the real world, people may use it more than that. And I think that's part of the hesitation. I hope that does that address your question?
So I'm seeing some more comments coming in from folks who are kind of elaborating on a few of the things that you mentioned, Dr. Cardet. So I think that answer was probably pretty on the money, because we're getting folks writing in with supportive comments. One person says, we deal with this issue in pharmacy constantly because providers are writing according to Gina, and insurance providers, especially Medicaid HMO, will not pay for the inhaler increased frequency use and by what is on formularies. And then another person says, but it looks like 1.1 canisters more per year is much less than an ED visit cost. So talking about the competitive advantage of introducing that approach. And then we have Andrea Jensen is commenting, certified asthma educator here and asthma patient. I'm recovering from COVID and just spent the last month with my best friend, AKA the nebulizer. I was very sick and missed a month of work, but my husband was only sick for a few days. Then Dr. Perpich has jumped in saying, Symbicort is approved in Europe as a rescue. Gina has a global focus. Then Andrea says, again, I'm hoping the SMART therapy is quickly approved by insurance companies, some supportive comments for that. And then Dr. Perpich is giving some accolades. Excellent presentation. It's great to have more options and keep pushing our past norms. Absolutely. So we do have a few more minutes. We will get started with our next speaker, Dr. Timothy Doherty, who I know is here with us at the scheduled time of 10:25 to learn about vaping. So we have more time for y'all to ask questions in the chat for me to read out for Dr. Cardet to answer. So please feel free to take advantage of that. While I'm waiting for more questions to come in, I want to remind folks who are just jumping on the live stream of a few housekeeping items. Number one, if you're looking for CE credits for today, make sure you follow the procedures for the specific type of credit you're seeking. If you are looking for CHES, C-H-E-S, Certified Health Education Specialist credits, there is an additional form that you will have to fill out. It's a PDF that you can download from the conference website. And our Altus representatives are periodically putting the link for that form in the chat. If you're seeking other types of CE credit, you will get some follow-up about that from our event coordinators. And please also make sure that when you're doing your event surveys that are going to go out from SurveyMonkey early next week, that you do fill out the page that's about your licensure information. Okay, so that's a little bit of a different process depending on what kind of credit you're going to be seeking. And I see that Dr. Garcia has joined the chat to say, excited to be able to share more information with our providers, the advocate for patients, and overcome insurance problems in the pharmacy setting. Oh, and then Andrea is saying, sorry, that COVID comment was supposed to be for Dr. Buckstein's presentation, but apparently it didn't show up. So this is an important note about the event chat. Periodically, it may time you out if you're in there as like a temporary user. So make sure that when you're trying to submit a comment that you can see it actually posted in the feed, and that it doesn't say like you need to reconnect or something, because otherwise it might just show up like an hour later. So good attention to detail there. And then we have another question. Oh, you know what? We have another person saying that they never got their credits from last year's conference. I completed the survey and sent several emails. Is there any way to get last year's also? That would be a question for our Health Council colleagues. So do me a favor, person who submitted that comment, NMRN, go to the view guidelines area in your event view. It's the button right to the bottom left of the chat view. Use the contact information there to get in touch so that we can follow up with you. We'll have certainly our Health Council folks and possibly Altus as well follow up with you to see if we can sort that out. And then we have another comment and a question saying, in your study, Dr. Cardet, what was the common inhaled corticosteroid that was used? Were patients understanding the reasoning behind using both?
The first question is easy. It's QVAR, beclomethasone, 80 micrograms per puff. The asterisk to that is, do I have reasons to think there's something magical about that formulation over other inhaled corticosteroids? No, I think it's getting inhaled corticosteroids precisely at the right time when the body is, starting to have asthma symptoms. It's prevention. An ounce of prevention is better than a ton of cure, right? And a ton of cure often comes in prednisone or other systemic corticosteroids, right? Mm-hmm. Do patients understand the rationale? We had patient partners. I think we consulted absolutely every single thing, every study material that went out to the participants were first vetted by this group of patient partners that were representative from different sites throughout the US, equal representation of both Latinx and Black participants. I would say yes, based on those conversations, but again, it might not be a fair comparison, right? Those patient partners, the rest of the group. We had a subset of participants who exited the study and completed some questions. Most of them who were assigned to Part X, they felt better at the end of the study compared to those who were assigned the usual care alone. It was like more than twofold greater the difference of those who felt better on Part X compared to those who felt better on usual care alone. Does that address your question of did they understand exactly why they were doing this? No, I don't think so, right? It's unless you do qualitative interviews and you elicit that from the patient themselves, then I don't think you can get that straight answer. We're putting in an implementation and dissemination grant now to PCORI. We want to get this to clinic. I think we have a chance. I was thinking about this, right? It's a 15% reduction in asthma attacks, in ER rate, likely in ER rates, likely in hospitalizations. If we disseminate this nationally, those are big numbers, right? It's like there's like at least 2 million asthma attacks per year. 15% less than that, we're hundreds of thousands. Does that address your question about do they understand, why we would be doing this? I'm not sure, but it's something we should find out for sure.
Definitely. And I see that in follow-up to the question about the CE credits from last year, we've got some of our coalition management folks from Health Council of Southeast Florida saying, please email us at FLAsthmacoalition, one word, at gmail.com. We will look into this. We will definitely not leave you hanging, NMRN. And if anybody else is in a similar situation with your CE credits from previous year's summits, definitely email the Florida Asthma Coalition general Gmail address and we will help you out. Then I see a comment in the chat from Dr. Dunham. The word steroid is still scary to many patients, absolutely. Education about the safe use of inhaled corticosteroids for asthma control is a must. I can tell folks, I'm pretty open that I've been taking QVAR for years to help with some of the lung issues from my CF. And it's done wonders for me, and it does not have the same kinds of really big side effects that being on, prednisone or methylprednisolone repeatedly would. It's very, very different. Doesn't mean that it necessarily is a fit for everybody. So talk to your providers, but it is not the same experience. I was on oral steroids a lot as a kid, and it's night and day. Then Katie saying in the chat, handouts with the difference between ICS and oral use would be helpful for those patients.
Could you repeat that? because I wanted to address the difference between ICS versus systemic steroids. Because one thing that often helps is converting the units. Because ICS is presented in micrograms, whereas prednisone is presented in milligrams. And, you know, it's 80 versus 40, and people, what's the difference? It's steroids, it's steroids, it's steroids. Convert it to micrograms, right? So it's 80 micrograms puffed to your lungs compared to 40,000 micrograms that enters your system and goes everywhere, you know, and there's solid data behind what are the effects of a single oral corticosteroid burst associates with increased all-cause morbidity, all-cause mortality, whereas one puff does not.
Absolutely.
I'm sorry, what was the question? Something about socioeconomic status.
Oh, I am not seeing that. I just read out a comment that said handouts with the difference between ICS. Oral use would be helpful for those patients. So not SES.
Okay.
It would be very relevant for our summit.